across the world to really work hard to do something really good for your patients. On the course conclusion, I'm going to include a little bit more educational material. So one of our speakers got sick and wasn't able to deliver the curriculum on Acuros and Monte Carlo. So I'm going to take a little bit of time initially to go over that, which I think will be some very helpful clinical information for those of you using it or thinking about moving to one of those two algorithms. I'm also going to give a quick overview on just sort of some advice on chamber selection, which a couple of my colleagues and I felt was quite important to really give that sort of more explicit clinical advice. Chamber selection is such an important thing, and it's a difficult thing for all of us. And so hopefully that will be quite helpful in your work. Then I'll give just a quick summary of some of the key points from the course: commissioning, patient-specific QA, treatment planning. Obviously, there were also the breakout sessions for contouring, which are of vital importance, and then just a take-home message at the end. So let's go ahead and get started. You'll be able to see the same table of contents at the top of my screen so that you can follow along with where we are in the presentation. So quickly about Acuros and Monte Carlo. So I'm not going to go into the theory, just not quite enough time in the presentation, and I'm going to focus on more of the clinical aspects. But just basically, you got the two very sort of bird's eye view definitions. Acuros solves the linear Boltzmann transport equation and directly accounts for the effects of heterogeneities in dose calculations. It calculates dose to tissue. Same with Monte Carlo. They both calculate dose to tissue. Note that most type A algorithms like AAA are calculating dose to a scaled density water. So it's a theoretical concept. It doesn't exist in nature, but it works pretty well for electron density and hence the Compton scattering, which is the predominant factor in megavoltage photon beams. So the Boltzmann transport equation is the governing equation that describes the macroscopic nature of radiation particles as they travel through a medium. The linearized form of this is the linear Boltzmann transport equation. This assumes that particles only interact with the medium and not with each other, which is valid in the absence of an external magnetic field. The equations are quite complex and can't be solved directly, so Acuros uses a sophisticated numerical methods to solve this. Monte Carlo, on the other hand, comes to the same conclusion as the solving of the linear Boltzmann transport equation, but does this through the direct tracking of millions of individual particle histories, each with its own set of scientific probability distributions for events. Again, a very rough overview of the definitions of these two. The idea is that they're highly precise and they calculate dose to tissue, not dose to scale density water. So here are just a couple of images. I think everyone is familiar with how good Monte Carlo is and how it's generally considered the gold standard in terms of treatment planning systems. This is a comparison from the Acuros XV manual from Varian, which shows how closely Acuro compares to Monte Carlo in various situations and various inhomogeneities. So quite close to each other. So how does dose to tissue affect us when most of our historical data comes from scaled density water? So let's take a minute first and look back at some basic chamber theory, which I tend to do in lots of my lectures. I won't read all of this for you. It's here for you if you want it. But basic, cavity theory. So the idea is, and I've highlighted it in these red circles, the basic idea is that with small cavities, we are basically assuming that all the electrons from the photon field, the secondary electrons from the photon field, are generated in the medium outside the cavity, and they traverse that cavity, thus depositing energy. And in that, we're talking about stopping power ratios, as the electrons generated outside the cavity traverse the cavity, depositing energy. We're looking at stopping power ratios to go from medium inside the chamber to the medium surrounding the chamber. If you're talking about large cavities, you're talking about mass energy absorption coefficients, as you'll see in the second circle there. So you're talking about most of the interactions, the secondary electrons being generated from photon interactions inside the cavity. So small cavities, stopping power ratios; large cavities, you're talking about mass energy absorption coefficients. Okay, basic cavity theory. So if we take this to the determination of absorbed dose in a treatment volume, so if we're talking about large volumes, again, we're talking about mass energy absorption coefficients. If we're talking about small volumes inside a larger volume, you're talking about stopping power ratios. So this goes into, if we want to go from dose to dose to water, it makes more sense to use mass energy absorption coefficient ratios from the medium to water rather than stopping power ratios. You can see in this where I've highlighted on the right side, this was intended to provide dose to water values for small. So the use of both Monte Carlo and Acuros, I don't know where I put it. The use of both Monte Carlo and Acuros both come to the same conclusion, slightly different ways, but similar to the concept of stopping power ratios, to go from dose in medium to dose in water. Now, stopping power ratios works for small cavities, and small meaning small in relation to the path length of a secondary electron. So the path length of a secondary electron in tissue is going to be bigger than the path length of a secondary electron in bone. So the smallness of that cavity in bone would be even smaller than the cavity in tissue. And so the two methods of doing it, it says here on that right side, this was intended to provide dose to water values for small tissue structures such as blood vessels and osteocytes in large heterogeneities such as bone. However, there are several practical issues in radiotherapy treatment planning, evaluation, dose prediction, because significant up to 11% differences between dose to medium and converted dose to water in treatment plans. And we'll look at that more later in this presentation. So here are a couple references that show mass energy absorption coefficient ratios. Notice on this left side it's water to medium, on the right side it's medium to water, so just be careful about what that means. So in those two boxes for 6 MV and 18 MV, if we're looking at medium to water for all of them, then they are all less than 1, right? Because that 1.036 is actually water to medium. So if we look at medium to water, it's closer to 0.96, right? So they're all less than 1, which all show that converting to dose to medium from dose to water, you're going to get less dose for the same fluence. And then on the right side, we've got stopping power ratios. And you can see that some of those are significantly higher. So that very top line around the 1.1 correction factor, or that 1.1 factor for 6 MV photons, that is for dose to bone, cortical bone. The next one around 1.03 or 4 is soft bone. And then you look at about 1.01, you're looking at lung tissue, which is pretty close. So you can see there are some big differences in stopping power ratios compared to mass energy absorption coefficient ratios. For bone, it's giving 1.1 for stopping power ratios, but for mass energy absorption coefficients, it's giving a value less than 1. So the two methods of converting dose to medium to dose to water will give completely different results, as you can see from these two values for stopping power ratios and mass energy absorption coefficients. Okay, so what does this mean for muscle, bone, and lung? First, let's look at muscle. Okay, so if you remember here, if we look at muscle for the mu-en over rho for, say, 6 MV or 18 MV, it's a factor of 0.99. So when you go from water to muscle for the same fluence, it's smaller by 1%. Okay, so that's that first point. For the same MUs or the same fluence, there will be about 1% less dose to tissue relative to algorithms used for scale density water, such as AAA. Similarly, if we are to optimize a plan with Acuros or Monte Carlo to give the same dose distribution, as an algorithm using scale density water, the actual dose to tissue delivered to the patient would be about 1% greater. Okay, it's a very small clinical difference. This should have very little clinical impact, but might slightly shift constraints in literature in the future. For example, the V105% constraint for breast plans. Now this, in reality, with Acuros and Monte Carlo, that'll be more like a V104%, which could have big changes in DVH. Little effect on clinical practice though. Think about this as you're dealing with your second check software or for any sort of quality assurance with chambers and solid water. So if you calculate a 10 by 10 field on a solid water phantom using Acuros, giving dose to medium, it will calculate 1% less dose to medium than what you measure with your farmer chamber and water using TG51. So for example, let's say your setup is 10 by 10 field, 100 cm SSD, and a depth of 1.5 cm. And you're given 1 centigrade per MU in water for TG51. Now Acuros is going to give you 0.99 centigrade per MU. So make sure that your second check agrees with this, your second check software agrees with this. Any measurement results, make sure that you understand this difference between water and tissue. It's generally a 1% correction factor. So now let's look at bone. So again, we'll go back to this page and we'll see that bone for a 6 MV beam, which is what you'll mostly be using for a VMAT, sometimes 10 MV. But for a 6 MV beam, you're looking at a 2.5% decrease in dose to medium relative to dose to water for the same fluence. That's on average. It could be a little bit less, a little bit more. So here, this is a paper from a group in Australia. The picture on the left is done with AAA. And then they've taken the exact same fluence and recalculated it with Acuros, dose to tissue. And what you see is an apparent reduction in dose to bone. However, the actual dose to the patient is the exact same. We did not change the fluence from picture A to picture B. The exact same fluence on both, meaning the exact same dose to the patient in reality. However, the two algorithms give different results. Okay, so for bone, this is quite important because this could be, 3%, even 4% different in high density bone. And so there's a really nice excerpt from that same paper. But basically what it's saying is there's a really narrow therapeutic ratio for lots of head and neck cancers. We're going to very large doses, and that means we're also on the very edge of a lot of organ at risk tolerances for head and neck. And one of these includes the mandible. So if historical data is for scale density water, and we're right at the border of these organ at risk tolerances, mandible tolerance, then if you now calculate in Acuros and give the exact same dose distribution with ice-dose lines, you could actually be giving a 2, 3, 4% hotter dose to the than historical AAA data. And so this now becomes important in terms of what you're actually doing to a patient. So keep that in mind. So I tell my doctors and my physicists and my dosimetrists, make sure that you keep the mandible even cooler when you're optimizing on head and neck patients with Acuros, because it's a few percent hotter than what we used to see in treatment planning systems. That doesn't necessarily mean that you want to keep it cold. This is something to discuss with your doctors, but at the least, make sure that you don't have hotspots or keep your hotspots as low as possible. Okay, now let's look at lung. So lung is the most complex. So again, if we come back here, we see the mu-en over rho. If you make that medium to water, so lung to water, it inverts that value. You're looking at, a 4 to 6% decrease in dose for the same fluence. That 1.036 becomes, 0.94, and then for 18 MV it becomes even smaller. So for VMAT plans, you're looking at 4 or 5% reduction in dose to tissue for the same fluence. Okay, so what does that mean? For the same MUs, there will be a 3 to 5% less dose in the lung portion of the PTV relative to algorithms using scale density water. such as AAA. In addition to this, there will be a decrease in dose at the lung tissue interface due to an overestimation from type A algorithms. Okay, they can't handle the boundaries as well as the type B algorithms. So there's a more realistic buildup of type B algorithms, which shows the reduction in dose at that boundary. In addition to this, there will be an overestimation of lateral scatter into the tissue GTV from the lung portion of the PTV with type A algorithms. So type B algorithms handle lateral scatter more appropriately. Type A algorithms will overestimate in general that lateral scatter contribution, hence giving a slight increase in the GTV dose due to the lateral scatter only. So the following page is a worst case scenario. So this is a GTV with PTV in the lung treated with CyberKnife. So CyberKnife has two algorithms. It has the ray tracing algorithm, which is a very simple pencil beam, which is great for things like brains, but it's not so good for things like lungs. So it's a very simple algorithm. And then Monte Carlo, which is in the red. Hold on, buddy. And so this will be an exaggeration of what you would find with with AAA or collapsed cone. AAA would be significantly better. Collapsed cone would be even better than that. But this shows you the general concept of differences. So this is central axis. So if we look at this top figure, and then if you look at the middle figure of the top figure, this is central axis. So you see the overestimation of dose in the lung portion of the PTV, right? Because of that mu En over rho. You see the overestimation of dose in the GTV due to the enhanced lateral scatter type A algorithms. And you also see the buildup at the interface for type B algorithms that you don't see with type A algorithms. And then the PDD on the right is on it's going through the lung portion of the PTV, not going through the GTV. So again, you see this big difference in dose due to the mu En over rho. Again, this is sort of worst case scenario, but it shows the idea of type A to type B for lung GTVs and PTVs.
Hey, Adam, I think there's a question in the chat.
Sure, sure.
It says, how fluents can be same using different algorithms?
Okay, so that's a good question. So going back to this, So this is not something that you can do, I think, very easily at your own clinic. So this was some in-house software developed by this group in Australia, which allowed them to put the exact same fluents from AAA onto Acuros for this research paper. Does that answer the question? The idea is basically, in theory, if you have the exact same fluents and use two different algorithms, this is what would happen. Okay, sure. And okay, so we move on with lungs. So because of these reasons, this is where RTOG has required this 10% decrease in prescription dose for type B algorithms for peripheral lung tumors. So instead of, say, 3 times 20, you're looking at 3 times 18, right? However, in reality, it is not a one-size-fits-all. The smaller the lesion, the greater the ratio of lung PTV to tissue PTV, and hence the greater the reduction in GTV dose for type B algorithms relative to type A algorithms. Again, that's theoretical concept. It does apply. However, you still have to follow literature and protocols for your prescriptions. So don't deviate and make your prescriptions even lower for a smaller GTV. Okay, you still need to follow literature and protocols for your prescriptions. Because of the mass energy absorption ratio of lung to water causes a reduction of dose relative to scale density water for the same fluents. Remember, so we've got, for the same fluents, we've got less dose to tissue in the lung portion of the PTV. What this does is, if you optimize with the type B algorithm in order to get the same isodose lines on the lung portion of the PTV, you actually have to increase the fluents relative to a type A algorithm. Okay, to make the isodose lines look the same on type A and type B in the lung portion of PTV, you have to increase the fluents in the lung portion. Now what this does is slightly increases your organ at risk doses, but it also increases your GTV dose. So note, we have a GTV because it moves throughout the PTV. Well, as your GTV moves from an area of lower fluence into an area of higher fluence within the lung portion of the PTV, it's going to increase that GTV dose, right? Because now it's moved into a higher fluence, there's buildup in tissue, it increases the GTV dose. So you can look at a picture of this. So here are different ways of drawing GTVs, ITVs, PTVs, and densities. The color of the darkness of the gray corresponds to the more tissue density. So here's your free breathing scan, where it's just the GTV, and this is all sort of lung PTV. Here's an average intensity projection, and the PTV is still lung portion of PTV. Here's where they've made that whole ITV the same tissue density as GTV. Here's where they've made the whole PTV the same tissue density as GTV. And here's where the ITV is the same tissue density as GTV, and the PTV is some intermediate tissue density. And so what they've done is they put a piece of film in the GTV of a phantom, and they've had it moving throughout a plan optimized with a type B algorithm. And so you can see, for example, here's the free breathing. As it moves, so here it is in the center. As it moves to the outside, it's moving into an area of higher fluence, right? Because we need more fluence because that mu en over rho for the lung to water. When it moves into an area of higher fluence, the buildup in the GTV adds dose on these sides. And you see the same for the average intensity projection, a little bit more for the ITV. When you look at the whole PTV done as the same density, where the entire, this is for the PTV, all the same density, you can see that the GTV has the same dose throughout, right? Because the fluence hasn't changed no matter if you're up here, here, or here. Whereas for the free breathing, for example, you have higher fluence here, lower fluence here. When the GTV moves into an area of higher fluence, with buildup, it increases the dose. Okay, so it's a nice example of sort of what's going on when optimizing with type B algorithms versus optimizing with type A algorithms. Type A algorithms, you won't get this. Warning about conversion of dose to water for type B algorithms. So again, back to this, so here's the actual explanation. This is what I was looking for earlier. So Monte Carlo uses explicitly stopping power ratios. Acuros XB does something very similar, slightly different. But again, back to what we discussed earlier, this dose to water, the dose to water is supposed to mean just for a small tissue voxel or a small detector water equivalent within a homogeneous medium. So look what happens when you convert from dose to medium to dose to water. So here's from one paper, and it shows here's the PTV, which is mostly bone, and you've got compact bone dose to medium is this red line, and then this green line is compact bone dose to water. It's a significant overestimation by about 10%, and that's because it used stopping power ratios. So be really careful. I would advise don't use your algorithms to calculate dose to water, because it's not giving the same result as what you would with a scale density water algorithm. It's doing something different. It's the purposes of dose to water for Acuros and Monte Carlo are not to give something equivalent as a type A algorithm, and it's not to give something really meaningful for an entire dose distribution within a body. As you can see, major differences in bone. That is not correct. Here again, from another paper, you see a phantom being irradiated and a little slab of compact bone. And you can see dose to medium, again, is the red, which decreases due to mass energy absorption coefficient ratios. And you can see the blue up here is dose converted to water using stopping power ratios. So again, big differences. And you can see, let's see, dose to water. This is electron density only, the green. So this is something more like a AAA. Is closer to what you would expect with dose to medium. Again, off by the amount of the mass energy absorption coefficient ratios. You can see at the boundaries, if you look really closely, sorry, it's a little bit zoomed out at the boundaries, you do see the more appropriate doses from the dose to medium because of the type B algorithm abilities to handle what's happening with electrons at the boundaries. 30 minutes, okay? Sorry, my son is here working from home. So now that's it for Acuros Monte Carlo. Does anyone have any questions on that? If so, just put in a message. Hopefully it's very clinically relevant for you and gives you a better idea about how to handle it within a clinic. Okay, so now a quick discussion on detectors. Again, I want to give you a nice general clinical overview with some advice on what detectors to use where. So my recommendations for chamber choices are going to be for large, small, and very small fields. So I'd like to define what large, small, and very small is. You'll see these lots of times in literature. People will say large, small, very small, but what does that actually mean? That can be difficult as well. Okay, I've got this chamber. I want to use it for a small field, but what does small field actually mean? So the way I'm defining it, large field is anything where the field is greater than twice the radius of the lateral charge particle equilibrium plus the diameter of the actual chamber. So you start talking about small fields when you lose lateral charge particle equilibrium. That's when you start changing how chambers act within a field. So if the field is larger than the diameter of the chamber plus that distance to ensure lateral charge particle equilibrium, you can consider it as a large field. So here's a definition from IEA for what the radius of the lateral charge particle equilibrium is relative to either your PD10X or your TPR 2010, depending on if you're using IAEA or AAPM. Small fields I would define as, again, the lower limit of the large fields, so this lower limit, all the way down to 2 cm. Very small fields will be defined as 2 cm and smaller. Okay, so those are my definitions of large, small, and very small. There's a really good resource from PTW. So here's the website here. It's a great thing where you can go there and you can choose what you want to do. So for example, from the drop-down menu, I've chosen output factors, very small fields. It gives me a list of the chambers that you can use. So these are all the chambers that are acceptable to use from PTW, and it lists them with the number of stars and how good that they are at handling it. So all these are acceptable, where it's saying that the microdiamond and the unshielded diode are the two best to use, but the others are also appropriate. It's a really helpful tool. It's specific to PTW because it came from the PTW vendor, but it's helpful no matter what manufacturer chambers you use, because you can use this tool. It'll show you what chambers PTW recommends. You can extrapolate that to any other vendor. So if you have an unshielded diode and you see, okay, PTW is recommending an unshielded diode in this case, then yours should work as well. If it's unshielded, it's a diode with similar specifications to this. It's a really helpful tool, which I would recommend. Okay, talking about large field PDDs. So the gold standard, according to lots of literature, including the IAEA, is the parallel plate chamber for large field PDDs. It's the best at build-up dose. However, throughout the PDD, it's the most susceptible to p-ion throughout the PDD. Okay, so especially for large field and deep doses, you can actually get up to 2.5% error if you don't correct for a p-ion throughout the PDD with the parallel plate chamber. However, if you do correct for p-ion, it is the gold standard. Next recommendation would be a small volume ion chamber without a high Z electrode. Typically, you'll see in all my recommendations to not use something with a high Z electrode because this introduces an over response to low energy photons. But these high Z electrode chambers are sort of being not made anymore by vendors. So use a small volume ion chamber. Small volume means less volume averaging in the depth dose direction. So around sort of D max, you can get some volume averaging with the larger chambers. Lower Z means less dependence on scatter for large fields and deep depths. The next one, a micro diamond. You'll find that a micro diamond can be used on almost everything. It's a really nice chamber. Then I'd say medium-sized ion chamber, something like a CC13, a semi-flex 3D. Again, I didn't say this earlier. I want to point out that I may reference certain manufacturers or exact chambers. This is an example, and you can find similar chambers with similar characteristics from many manufacturers. But I thought it would be nice to actually give you examples of real chambers that I would use, and then you can use that to look at chambers from other manufacturers or chambers that you have that might be similar in size, composition. You can choose the best detector accordingly. And then the last one that can be used but not recommended would be a shielded photon diode. So again, you can use this. There are certain manufacturer limits on field size, and you can look at the manufacturer limits for that, literature on that diode. But I would recommend do not use a shielded diode if you have one of the above ion chambers to use, or micro diamond. And don't use unshielded diodes. Note that if all are corrected for p ion and p polarity, results are very close, within 0.5%, but you could get up to 2.5% for a 40 by 40 field size at 30 cm depth for a parallel plate chamber. Again, if you use something like a semi-flex 3D, a CC13, the largest error without even correcting for p ion would be less than 1%. Small field.
And then Adam, it looks
Sure.
like we have another question in the chat. Sorry
Okay.
to interrupt.
No,
The question is, do we need to correct for pion for relative dosimetry like for PDD?
Okay, very, very good question. And I'm going to touch on that in a few slides, but I'm happy you asked it now. So my recommendation, as you'll see in a later slide, would be to use something like a CC13 or a semi-flex or a small volume ion chamber, and probably not a parallel plate chamber. The parallel plate chamber can give the best results, but at what cost? You're looking at maybe a slightly better dose at buildup, but is that really that clinically important? Probably not. Something like a small ionization chamber, a CC01, or even a CC13, you don't have to correct for p ionization. That becomes sort of cumbersome and complicated, and you're still going to get results correct within 1%, even for the largest field size at the deepest depths. So you will not need to correct for p ion. If you use a parallel plate chamber, that's the only one where you might have to correct for p ion if you use it for large fields at deep and going to the deep depths of PDDs. So to answer your question, no, you don't need to use p ion corrections, only possibly with a parallel plate chamber at very large fields. But again, clinically, I would recommend using something other than a parallel plate chamber just to rule out the possibilities of that error. Good question, very good question. Okay, we move to small field PDDs and very small field PDDs. The same for both sets of field sizes. The best one to use would be an unshielded diode, followed by a micro diamond, a shielded diode, and a micro ionization chamber. All give clinically same results. So if you look at this recent paper from Garnier, you can see they only did 4 of the chambers, or 3 chambers in Monte Carlo, but if you read the discussion in there, for all chambers, unshielded, micro diamond, shielded, micro ionization chambers for PDDs, they are all giving clinically equivalent results. And here's another paper, image from a paper at the bottom, where you can see that for the shielded and unshielded diodes, they're giving clinically equivalent results, PDD at a depth of 10 cm. The only two that start deviating when you get down to 1 cm are the RK ionization chamber, which has to do with volume averaging in that case. Okay, just a couple quick notes. For very small fields, be careful on the size of the ion chamber if you use an ion chamber. They can over-respond at depth due to volume averaging pronounced at Dmax relative to depth, thus increasing PDD at depth. So in the case of this pinpoint, it didn't cause significant volume averaging, and the PDDs were the same, but be careful about the size. Something that's a little bit bigger could possibly cause an increase in PDD at depth. Note that for small and very small fields have minimum in-scatter photons. It's mostly scattered out, so beam spectrum does not change much with depth. Thus, we can use shielded or unshielded diodes interchangeably for small and very small field PDDs, especially less than 2 cm. And very important to have your chamber centered on the radiation at all depths. So this will be your biggest source of error. Centering and making sure that your radiation beam is perpendicular to your water tank and that the mechanics of your water tank are parallel to the radiation beam. So you want to check with radiation that your beam is centered at multiple depths. Otherwise, that can really skew your PDD for small field sizes. Output factors for large fields, something like a semiflex 3D would be ideal. Any ionization chamber without a high Z electrode, a farmer chamber would be fine, or a microdiamond. Output factors for small and very small fields, again, interchangeably. You can use a microdiamond, almost no correction is probably the best one. An unshielded diode would be the second best. You're going to correct down for this. So when I'm talking about these correction factors, I'll refer you to IAE3, the new document on small field dosimetry, and it suggests that you use correction factors due to the under or over response from various detectors. So predominantly due to the density effect. I won't go into small field dosimetry in chambers in depth. That's a whole nother presentation. But predominantly due to the density effect, you have an over response from diodes and an under response from ion chambers. So you want to use to apply these correction factors. So an unshielded diode, you would correct down. Preferably, the diode would be parallel to the beam. The next detector that you can use is your smallest ion chamber available. Again, parallel to the beam when possible. And typically, this corrects with TRS 483. So examples would be an A16, a CC01. Note that for TRS 483, the only ion chamber allowed to be used for correction factors for a 5mm cone is a CC01. So again, the unshielded diode with microdiamond are preferable. Shielded diodes you can also use. However, these are less preferable to unshielded diodes because they have bigger correction factors. Bigger correction factors because they have more density and exaggerate that density effect. It's a really good idea when possible to measure with 2 different types of detectors. Preferably one that corrects up, like an ion chamber, and one that corrects down, like an unshielded diode, and they should converge on the same result after correction factors are applied. It's a really helpful tool to make sure that your setup is correct and that 2 different devices agree, because there's a big uncertainty in measurement with these small field output factors. Here's a picture showing what happens to the output factors with different detectors as you go down in field size. Down in field size is going to the right. You can see that your diodes will tend to move up on the plot, over responding. Your ion chambers move down on the plot due to under response. And your diamond, microdiamond, that purple one, is actually pretty good, just a few percent high. Note it has EBT3 film here. I'm going to touch on this later. Film is a great tool to use on almost everything due to its tissue equivalence and hence lack of energy response, as well as its resolution. However, film is extremely complicated, and so I would only recommend using film as a second check for something else. To use gap chromic film properly using correct protocols is actually quite difficult. Profiles for large fields. So you've got a microdiamond, and check manufacturer limits. I would always spot check with like a 30 by 30 or something like that. Any detector that you want to use relative to sort of a standard detector like a CC13 to check and make sure that it at least agrees in field and out of field dose. and that by using a better detector for the job, you would just be improving basically on the penumbra. But you don't want to improve on the penumbra at the sacrifice of in-field dose and out-of-field dose. So for these large field profiles, I'd always do a quick spot check versus a CC13 with all of these chambers. So a microdiamond, I should have put microdiamond, I don't know why I put diamond or microdiamond. Sorry for that. Microdiamond, a small volume ion chamber like a CC01 should be an outstanding detector to use. A shielded photon diode for all field sizes that the manufacturer recommends. Again, checking it relative to a CC13 for in-field and out-of-field dose. And a CC13 is fine as well. So note that relative to the first three detectors, the CC13 size ion chamber would have a slight widening of the penumbra, but this is less important for large fields when you're talking about clinical use, right? So you're more worried about sharp penumbra for small field dosimetry. So when you're modeling a beam, as long as you model your small field penumbra well, your large field penumbra is less important. So CC13 can be used just as well.
And then it looks like we have another question in the chat.
Sure.
And the question is, can we use pinpoint chamber for small fields?
I'd have to look up for small field. Yes, you can use a pinpoint chamber for small field. So for output factors, so you can see the pinpoint in this plot. So you can see it here and here depending on the directions, right? So axial, this is parallel to the beam. This is perpendicular to the beam. See, perpendicular, definitely don't use it that way. Have it parallel. And you can see that at a certain point it breaks down and your correction factors are just going to be pretty high. So I'd be a little bit wary of using a pinpoint for 5mm cones if you have it, because the correction factors are going to start becoming too big. TRS 483 does not recommend it. However, for PDDs, you can see that the pinpoint does very well, even for very small fields. This is a 4mm field size, and the pinpoint did just as well as the SRS diode. So I'll have references at the back of this, so feel free to, at your convenience, go through some of these references, and you can start looking at your chamber specifically as well, and how they work relative to some of the literature. Okay, we'll go to profiles for small and very small fields. Unshielded diodes is probably the best. Then you've got microdiamonds, shielded diodes, and micro volume ion chambers, again like the CC01. Note that unshielded diodes are a little bit more tissue equivalent than shielded diodes for some improvements, not clinically significant. The shielded diode is going to be slightly better for out of field dose than the unshielded diode, but it's completely not clinically significant. So any of these chambers could be used. Note that for the microionization chamber, however, is not recommended if you have one of the first three, because you'll get an extra 1mm or more of expansion of penumbra. So recommended only if you do not have an unshielded diode, a shielded diode, or a microdiamond for small and very small fields. Note that there's little effect from scatter radiation out of field to increase dose for diodes. Note that the scan direction is important for perpendicular devices. So note for ion chambers, it's worse in plane than cross plane. Flatness and symmetry is the same for all four chambers. Note that size of the detector becomes most important for these small and very small field profiles. So the size of the diamond may not be as small as a diode. So for extremely small field sizes, a diode may have a sharper penumbra. At very small field sizes, detector size becomes the most important factor. So the detector with the smallest resolution, typically one of your diodes, is going to get the best results. Again, this shows some images. This top left shows a shielded and an unshielded diode, a number of diodes, and how well that they're doing. Here shows the SRS diode relative to Monte Carlo. It's almost spot on, pretty impressive. Here's film relative to Monte Carlo. Again, really, really high resolution. This shows a pinpoint into pinpoint 3D. So I haven't used these two chambers, but I'm assuming from the plots that the pinpoint 3D is slightly larger diameter, hence a little bit more volume averaging. The pinpoint actually does quite well, this green, but not as well as you can see. So definitely use a diode if you have it. Patient-specific QA for VMAT or IMRT plans, you're going to want to use an ion chamber for that, something like a semi-flex 3D, that size, or a small volume ion chamber without high-Z central electrodes, like a CC01. If you're using a small volume ion chamber, make sure that you subtract out any leakage from it. That could be an issue. Also, you could have a little bit of cable effect from small volume ion chambers. So a semi-flex 3D would be the best for larger VMAT plans. For small volume ones, your best option will be a small volume ionization chamber. Again, don't use detectors with angular dependence, diodes or microdiamonds. So quickly, a summary, if you could buy anything that you wanted to buy, your admin was really nice, I would buy a farmer, a microdiamond, a small volume ionization chamber like a semi-flex 3D. I'd buy an unshielded diode, a micro ionization chamber, plus any reference chambers for scanning. For example, if I'm going to scan with a diode, I'd need a second diode for reference. If I'm going to scan with an ionization chamber, I need a second ionization chamber for my reference for scanning. That's ideal scenario. A list of minimum detectors necessary for VMAT. This is bare minimum. Without the use of SRS Sbrt, you can get by with a farmer and a semi-flex 3D, plus your extra reference chamber for scanning. The minimum detectors necessary for VMAT with SRS and Sbrt, you'll still need the farmer and the semi-flex, and then you'll have to add either a microdiamond or an unshielded diode, okay, to do those profiles and output factors for small field dosimetry. And obviously plus your reference chambers. Again, notes about film and MOSFETs. Diachromatic film is an excellent tool for small field dosimetry, output factors, PDDs, profiles, patient-specific QA, high resolution, little energy dependence, but it's prone to errors in its commissioning and use. It can be difficult. I would recommend it as a second check, not as your primary. MOSFETs are also a very good tool with high spatial resolution, but they have a short finite lifetime, so I would not recommend them for many departments where budgets or infrastructure could lead to problems. Okay, so now we've gotten through all of that. I'll go through a brief summary of some of the high points of this course, the commissioning, patient-specific QA, and planning, and we'll move on to the conclusion. So I'll just briefly cover these three areas, which are awesome. Educators have just done a great job throughout the course. So commissioning, we want to talk about risk analysis and cost gain benefit. So with all of this knowledge that you picked out throughout this course, what's really important, right? So we'll take that example of large field profiles. So you've got the profile versus penumbra versus out of field dose, those three areas of a profile. You can have 1 to a few % errors in various regions depending on your chamber. For example, you could use a shielded photon diode to get better penumbra, but it could have issues with really large fields or out of field dose for large fields. You could verify the inner field dose versus your CC13. You can compare out of field dose with your CC13. But is penumbra really important for large fields? You can accurately measure penumbra for small fields, example, with an unshielded diode, and match your small field penumbra in beam modeling where it is more clinically important, and not worry that much if your penumbra doesn't really match on your large fields or if it's a little bit too big, because it's not really clinically significant. So I think a CC13 would be perfectly fine clinically for measuring large field profiles, given a risk analysis and the cost gain benefit analysis. We look at another example, depth dose. So back to that conversation about parallel plate chambers. It is the gold standard, but it's a little bit more susceptible to p-ion. But you can use a small ion chamber as well if you have it. But a CC13 will do a fine job within 1% for everything up to 30 cm depth, 40 by 40 field size. Not quite as good in the buildup region, but is the buildup region really clinically important? I think probably not. So if you look at commissioning, where you need to focus, things like small fields are prone to errors. Setup, orthogonality, detector centering, detector choice, output factors for small fields, focus on these areas. The point, with new Linux, maybe the best compromise to get good results within 1% and to reduce risk of large errors is to check golden beam data that your machine is within 1%. Tweak it to be within 1%, and then input golden beam data into your TPS. It might not be quite as accurate as if you did everything just perfectly, but clinically it's going to do what you want it to do with less chance of bigger errors. And then you can just focus on proper measurements of machine-specific parameters that you'll have to do with higher uncertainty and larger possibilities of errors. Things like your DLG, which we had a great lecture on that, output factors for SRS, Sbrt, so focusing on using the correct chamber, confirming with 2 chambers if you can, include redundant checks, multiple chambers devices, use the correct chambers, and check versus literature. So for example, your DLG after correction should be very similar to other people's DLG using this same machine after they've corrected it in the literature. I would say usually within 0.2 millimeters. So use literature as a reference as well. If you look at patient-specific QA, commission it well. Spend a lot of time on the commissioning, and then it should run smoothly from then on. Use 3 devices when you're commissioning, if possible. Always use an ion chamber as your gold standard. It's very simple and can give you an idea about where exactly you are. So use 15 to 20 plans in a high dose and a low dose area. Use this as a gold standard. There should be sort of a distribution about 0. Use 2 other QA devices if you have one. Borrow another one if you have one, but make sure that your QA device is now matching the results from your chamber. At the least, you should QA your QA device monthly. So for example, if you're using ART check, use a chamber once a month. If you're using portal dosimetry, check your portal dosimetry with ART check once a month. QA your QA device. Think about SRS Sbrt. You may want to use a chamber in addition to your QA device for every single plan until you gain enough confidence. And then QA those SRS Sbrt plans on a monthly basis, not on an individual patient basis outside of your primary QA device. For example, I just want to throw this out there. I've seen portal dosimetry with passing plans at a center, but it was commissioned improperly, and then they tweaked the DLG to make the plans pass on an improperly commissioned portal dosimetry. Hence, it looked like plans were passing. However, if you checked it with ion chamber, it would have become immediately evident that there was a problem. Errors hidden in systematic. Ion chambers, film, and detector arrays are gold standard. Now if we move to treatment planning, another critical section. So we had sort of a break-off section with the radiation oncologist where they focused on contouring. Again, we've got high dose gradients in IMRT and VMAT, so it's really important to have those contours correct, right? A lot more so than with 3D planning. So that's a really important thing, and I applaud everyone for going through, I think, 6 or so educational sessions on contouring. Extremely important. Treatment planning, this is, so everything that we've talked about so far, commissioning, patient-specific QA, you're talking about errors on the order of 1 to 5%. Not the end of the world, right? Yes, we want to do the best that we can, but you can get by with slight errors. Treatment planning, on the other hand, you can be on the order of 100% when you're talking about organ at risk doses. Huge impact on patient populations just by the quality of treatment plans. For example, just because you're a good planner and you focused on planning well, you can lower the parotid dose on a patient, and because you plan the patient will have saliva for the rest of his or her life. Whereas if that patient had gone somewhere else, maybe not, and lived a very difficult life after that. You can allow patients to swallow. You can allow patients to talk. You can allow patients to see just based on your treatment planning skills. Rectum and bladder issues on prostate patients. Every patient, no matter how low the dose, retreats, early side effects. Even give the example of a 45 gray pelvis plus periaortic nodes. Well, it's only 45 gray. You're not going to go above tolerances on anything. But maybe if you gave too much dose to bowel, the patient's going to have side effects. They may have to take a break from treatment. Well, a patient that takes a break from treatment for this disease could have a much, much worse prognosis. You could save a patient's life by lowering bowel dose. It's an amazing thing. Or lowering bone marrow dose and not having the platelets drop too low so that they don't have that 1 week break in treatment. A 1 week break in treatment or a GYN case of particular diagnosis could be the difference between life and death. It's amazing what you can do with treatment planning. My doctors used to thank us daily. Patients rarely had symptoms compared to before we did a big overhaul to the dosimetry program. I'll make one more point. I was at a proton therapy conference and they gave data, basically theoretical toxicity data based on DBH analysis. They did it 4 photon centers and 4 proton centers. Photon centers, A, B, C, and D, they had a big variation, and center D had really good plans. Proton centers, institutions E, F, G, and H, all had great plans, but they were all exactly like institution D, the photon center. So the analysis from that presentation is, well, maybe we don't need to spend a lot of money on protons. Maybe we just need better planners. Everyone should plan like institution D. That could be all of you in this course. Everyone should have great plans. And I want to make a point. So I think you all haven't gotten it yet, but you will this week. There was a little confusion on our end. So I did 2 treatment planning tutorial videos with the help of Cesar. We recorded these. It's a head and neck treatment planning video and a pelvis plus periortic treatment planning video. These are the same DICOMs and structure sets given for your practice plans. I've done video tutorials with comments on exactly how to plan incredibly well and incredibly efficiently. So I would highly recommend watching those videos and practicing what I've taught in those videos. You'll be able to do textbook plans. You'll be able to complete them start to finish in about an hour and a half, even the most complicated VMAT cases. So make sure you get those YouTube videos and please try and watch them. I think they'll be incredibly helpful for dramatically impacting your patients' lives. Last point about VMAT, use VMAT as much as you can. It's quick now. You can use it. We used to use it for like all of our palliative patients. A palliative patient is not indispensable, right? You know, we're treating them because we want to bring quality of life and extend their life in a quality way, not give them more side effects. If you can do a VMAT plan the same time as you do a 3D conformal plan and you can deliver it even quicker, why not use it? And just another note, please watch those videos that Cesar and I created. And I know I'm running about 10 minutes over. I apologize. We'll go to the conclusion. You know, I really want to thank everyone in this course. So I know we're all extremely busy in our clinics. I know a lot of you are very busy in your clinical workload. I think it speaks incredibly highly about your character to spend whatever it's been, 3 months or so, twice a week, hour to an hour and a half per day going through this curriculum. It really shows your dedication to the profession, the dedication to your patients. You know, I applaud you for that. I don't know how to thank you enough for going through the effort to ensure that you're giving your patients the highest quality work that you can do. You're setting the tone for your countries and regions. I think it's a really cool thing. So I've worked all over the world, in Africa, the Middle East, in the United States. And you'd be surprised that some of the quality of work that can be done all over the world, you know, you guys can do in general, honestly, a lot better treatments than the majority of, say, the United States and what I've seen in the United States. Yes, academic centers do excellent work, but there's a reason, you know, I took my mom to get treated with me in Qatar because I knew that we could do exceptional work. Which brings me to another point. Take pride in your work. Do such a good job that you would want to treat your own family member, that you would want to treat your mom. My mom did need treatment, so I was confident in my colleagues and the quality of work that we were doing in Qatar. And I'm so confident in the quality of my planning, I did her treatment plan. I didn't want anyone else in the world to do her treatment plan. So that's the sort of confidence that I want you all to have. Stay in touch with us. So, you know, I'm in touch with so many people that I've taught and worked with in the past, from Iraq to Iran to my friends in Senegal and Ghana. So keep in touch with us. Keep in touch with each other. If you all want to have each other's contact information, send that to your RCC delegate. Send your contact information, say that you want to give it to the others. Stay in touch with each other. The more people that we can talk to, the better. I think it's a really cool thing. I want to just also put this slide up here. A thank you to all the clinic coordinators at all the different hospitals, our RCC liaisons, John Pally on this call, our course director, who's organized everything, and in particular, my colleague Claire Dempsey, who helped me to design this curriculum from start to finish. So I want to thank everyone involved in this course. And I think John is going to jump on now and give you a few things about what's going to happen at this point now that the course is completed in terms of things to follow. So John, if you want to take over.
Good, Adam. Thank you so much. This was a fantastic wrap up and kind of touching on some of the high points of the course and covering some of the algorithms we weren't able to cover last week. We are concluding the course today. We do have one session that we weren't able to hold last week, which was to review the plans that were submitted. And we're really excited to do that. We think that'll be a helpful session. Cesar is going to lead that in about 2 weeks. We'll send you the information when we know exactly what day that'll be. With regard to
John, sorry, I want to say one more thing, and just about that plan competition. Just make sure, everyone, again, that you watch my planning tutorial videos. You should receive them in the next couple of days. I think it will really help you with your planning abilities.